We move on to our next speaker, Dr. ANIRUDDHA AGARWAL, who's from Cleveland Clinic, Abu Dhabi, and our alumni. He is going to talk about thick choroid in a patient with CSC. Is it a game changer? And the topic is important because everybody is talking about pachychoroid, and then there is a confusion, CSC, pachychoroid, the combination. So he's going to show us the cases to illustrate.
Very good morning. Thank you very much to Dr. Vishali ma'am for giving me this opportunity, and to AIOS. So my topic is thick choroid in central serous chorioretinopathy. Now we all deal with pachychoroid, and this is a term that is being used many times to describe a number of entities. When it comes to central serous chorioretinopathy, there is some ambiguity whether to label it as pachychoroid always, or you may have some occasional cases where the pachychoroid is not so evident. But definitely you will have a subset of patients where the choroid is thick. And these have some implications when it comes to the diagnosis and management. So I divide this into three parts. One is that presence of a thick choroid itself can mean that there is presence of probably more than one disease, and I'll show you how. So apart from CSC, these patients could have associated conditions. Now also the second question that I'd like to answer in this presentation is, does a thick choroid mean more exudation or more fibrin? And finally, does a thick choroid have anything to do with response to therapy? Do some therapies work and do some fail? So let's see this particular patient who came to me very recently. So he's a young male with central serous in the right eye. You can see that the choroid is thick. So despite your EDI OCT, even in the Middle East, some of the patients have very much pigmented irises and also the fundus. So you cannot see the posterior extent of the choroid on the OCT. But definitely the choroid is thick. There are central leaks on fluorescein. And in this particular patient, again, you see the fluid is so much in the center, you cannot do laser. And in this patient, I started him on eplerenone. So this is at 6 weeks. I don't start eplerenone straight away, but I start usually after 6 weeks of observation. Now, within 2 weeks of eplerenone, this patient has a reduction in the fluid, and the patient has an improvement in the visual acuity. The scotoma has decreased. You can see on the infrared that the density of the scotoma, or the dark area in the infrared image, has decreased in size. Now, we have seen from studies that patients with thick choroid have a tendency to respond better to eplerenone. In general, with eplerenone, the response will not be seen in 100%. With most of the studies, we see that the response is only in 30%. But probably there are some patients with thicker choroid who will respond better. So if you have a patient with thin choroid versus a patient with thicker choroid, then expect a better response. If a patient has thick RPE, chronic fluid, thin choroid, you may not have sufficient response to eplerenone. I tried to study a lot of literature, and in fact I did not come across any manuscript which tells us the response of eplerenone based on the thickness of the choroid. Now, does CSC with a thick choroid mean that there is another disease which is coexistent? Now, if you look at this publication from the Progress in Retinal Eye Research, this study quotes that although choroidal thickening is a component of pachychoroid, CSC is traditionally included in pachychoroid. Remember, it is still a gray area because you will have some patients who do not have a clearly thickened choroid. Now let's see this patient. This patient has a focal choroidal excavation. So if you look at the multimodal imaging, you will realize that this patient has some pachyvessels. Look at these arrows over here. This indicates that under the RPE, this patient with focal choroidal excavation, and that can be seen here, has pachyvessels. Now, over a period of time, this patient developed subretinal fluid. So there is subretinal fluid near the focal choroidal excavation. Of course, it can happen because of a choroidal neovascularization, but this is a published case which is showing you that there is a CSC. And if you look at the NFAS imaging, you have large dilated vessels, pachyvessels, which are passing in the center around the focal choroidal excavation. So you could have more than one condition coexist. We talked about ICG in the previous presentation. ICG is no doubt very important in pachychoroid. It helps to pick polyps. Polyps can coexist with CSC, and Dr. George Manayath has a publication in Retina on that. And now we are moving towards analysis, automated analysis. So in our lab, we are starting to analyze the choroid using automated techniques and to look at the choroidal vascular hyperpermeability on ICG as well. Now let me show you this case. You might get confused with subretinal fluid, and you might think that this is a patient where you would like to start eplerenone. So the OCT is showing you subretinal fluid, probably the choroid is thickened, and you look at the fluorescein angiography, you have some focal leaks over here. So be very careful if you have a thick choroid. This is a patient who has choroidal osteoma. So subretinal fluid associated with choroidal osteoma can mimic CSC. So just don't go by the thickness of the choroid, okay? You have to look at a number of aspects, and we talked about how important the ultrasound is on the previous presentation. So this patient actually received PDT, and with PDT there is complete resolution of fluid. So this could be a mimicker of CSC. Now, does thick choroid indicate that there are high chances of fibrinous CSC? So let's look at this patient. This is a patient who came to us from Sri Lanka, and this patient has multiple leaks in the center. There is one leak in the superior, near the superior arcade, but most of it is central. You can see most of the leaks are central. Again, it's not possible to laser. And we often have these patients who come with such a picture. This patient was 636 with significant amount of fluid, and there is some amount of fibrin. So, of course, we didn't have any other option, and in these patients, you'd like to start on eplerenone. Now, this is about 1 month after eplerenone, and this patient was on maximum 50 milligram per day of eplerenone. There is mild reduction in the fluid, but not so much. And this is almost 3 months after eplerenone. So, the point is that you can have a patient with very thick choroid. You can see that on the OCT, the choroidoscleral interface is not clear at all. Even despite 3 months of eplerenone treatment, you cannot make out where the sclera is. And is it that, thick choroid with a fibrinous CSC will give you a suboptimal response? We don't know. But these are patients who are very difficult to respond. They may not respond to eplerenone or any other treatments, like laser is not possible. So you are faced with a challenge what to do. I'm showing you another patient.
ANIRUDDHA?
Yes, ma'am.
There is a question. I think
Please.
he wants to look at the slide. Yeah, please do.
Intervene, please. I'm sorry.
That's fine.
Yes, what is there in the retina?
You mean
In
this?
all these images?
The
No, in the OCT scan.
The hyperreflectivity in the outer retina, you're asking?
Yeah, madam.
Yeah.
So this is actually the fibrin which is accumulated in the subretinal fluid. And if you read Bailey-Freund's papers, you will realize that this clear space that you see on the OCT, this is the area where the fluid is coming from. So that's why you will have a clear space, and the clear space is surrounded by that hyperreflective mass kind of a thing, which is fibrin. So this is all fibrinous exudation in CSC.
Previous, when you saw him first?
This one?
Yeah.
So here again, this is the fibrin, and you have a component of clear fluid. And of course, some of the outer photoreceptors are elongated, so which gives you those, long kind of hyperreflectivity. So this is the classic fibrin, how it appears on the OCT.
The eplerenone therapy had not worked.
So even despite eplerenone, this patient was on 3 months, no response.
Any other evaluation?
So this patient had a normal cortisol levels. We usually do late evening and early morning serum cortisol, free cortisol and urinary cortisol, and vinyl mandelic acid. So we have a panel in Cleveland Clinic where we evaluate for an endogenous kind of a cortisol increase, but this patient was completely normal. This patient incidentally had multiple evaluations for other neurological conditions. The pituitary microadenoma was also ruled out. So we were left with nothing but to treat,
Then what was the modality of treatment?
So this patient was continued with eplerenone. We don't have any other, we don't have PDT yet. PDT could be an option. We are probably getting the dye, probably even in India in July or August. We don't know, but PDT could be an option.
Okay.
The patient was from Sri Lanka.
Yes.
I don't actually know the situation over there. Evaluation for tuberculosis?
Was not indicated because there was no inflammatory reaction. So we did not evaluate for TB.
Angiography images?
I'm sorry, I don't have
Let's
the
move on.
angiography.
I am being told to move on. You can discuss it with Anirudh after that.
But I will address some of your points. So in this patient, if you see, you have an exudative retinal detachment with multifocal leaks, and we're interested in the right eye at this time. So if you look at the OCT, there is subretinal fluid, and again, elongation of photoreceptors, thick choroid. This patient was not so difficult. We did a focal laser. The leaks were not so close to the foveal center, and the patient resolved. This is the right eye on the top, but the question is the left eye. The left eye has this fibrinous exudation and thick choroid subretinal fluid. This patient came to us after 6 months. And this patient, I did focal laser and a plerinon, and you can see that this patient took a long time to resolve. Again, it took about 4 months for the fluid to completely go away. There was nothing else we could probably do, and this patient ended up with foveal atrophy. So patients with a really thick choroid could predispose to fibrinous CSC. It could take a long time to resolve, and these patients can have a high chance of atrophy. So I think the expectations should be clear with the patient. When you see the patient, I think it's important to communicate with the patient that you may end up with atrophy and you may not regain complete vision. So again, thick choroid with chronic fluid, persistent subretinal fluid, one option is PDT. We may get the dye back in, at least in UAE by July. Maybe it will come to India as well. So, but we're waiting to use PDT in some of these difficult patients. This is my last patient here. This patient is another example where you have a thick choroid and focal leaks in the center. You can see on the fluorescein. And this patient responded very well after PDT. And the important aspect is that PDT will give you something that a plerinon doesn't give you. PDT gives you reduction here at 2 months. PDT can cause choroidal thinning. So if you have a thick choroid, PDT is still an option. But if you have thin choroid, or if you have a very, sort of atrophic choroid, you cannot do PDT. Remember, a plerinon has no effect on choroidal thickness. So a plerinon is an option that you can use in both, but PDT, unfortunately, you can use only in some cases. Thank you very much. I'll be happy to take any questions.
Thank you very much, Anirudh.